Now we get to the point where we're asking you to be part of the dialogue. I also encourage any of our panelists who have either a question for one of their fellow panelists or a comment on something that they've heard to signal that, and we'll try to get to that fairly quickly. We have microphones. If you do want to ask a question in your own voice, go to the microphone, identify yourself if you would, and keep the question as brief as you possibly can so we can explore as many of these issues as we can. Zane, let me just reiterate my encouragement that you chime in with questions and comments at any point. And of course, if you have a question you want to write down on the green card in your packet, that's fine too, and we'll have it brought forward. Let me start off by kind of tying together some of the things that we've heard from several of our panelists, and it was triggered in my mind first when I looked at Keith Mueller's map of where the ACO spread is in this country. And although you make the point that there are, 17% of the rural counties have some sort of ACO presence, okay, 6 out of 7 do not, and there look like an awful lot of ACO deserts in what look like some of the rural states. And if payment reform is part of the answer and ACOs are one of the ways we're moving away from fee-for-service, is it important to try to get ACOs to move more aggressively into some of these areas that we're concerned about? And if so, how do we do that?
Great question. Excuse me. It is important to get payment reform and the move toward pay for value being a higher percentage of total reward than simply pay for volume. I think that general movement is critical and needs to occur almost everywhere. You know, if you look at that map, there are places in northern Montana, places in Wyoming where no, because it's just, you don't have the volume to make anything else work other than sustaining the fee-for-service environment that's there. But it may not always be the ACO shared savings model. There are some other models being demonstrated under the innovation grants from CMMI, other models being tried by major insurance carriers, like in our state, Wellmark. They all have that theme, though, of trying to do two things. One, set up a payment system that rewards high value and moves providers to even higher levels of value. And second, sets up payment systems in which providers benefit from lowering the total cost of care. And in fact, in some places now it's being called a total cost of care approach to how you pay providers.
Mm-hmm. Okay. Anybody else? Yes, go ahead.
Thanks. Bob Rohr, BMJ. Two questions for you. First of all, how do health outcomes, how does the life expectancy, et cetera, of rural versus urban populations differ? I mean, we've heard, let's face it, we're interested in outcomes. So what's the baseline difference between the two populations in terms of their health, overall health?
There have been some studies in the last year looking at mortality and it being low. People die younger in rural than they do in urban areas. And a new study they just released in the last couple of weeks from the University of Pennsylvania looked at what drives death rates, rural versus urban. And the findings were interesting. Yeah, in urban you're more likely to die of in terms of a violent act, but rural has a higher accident rate, and then that relates to the infrastructure for emergency care and things like that. Some of the statistics Ed cited about higher rate of chronic disease obviously leads to some of that lower mortality rate in rural areas. So there are some studies out there. How that factors into outcomes, I think that's sort of the alchemy people are trying to figure out. What measures are strong enough and relevant enough across the spectrum that you could potentially tie them to physician reimbursement or hospital reimbursement. We're just taking the initial steps there with value-based purchasing and the value-based modifier, but it's not something you can just sort of turn a switch on and do right away, but it is the point of emphasis, I think, moving forward.
Sort of a central report on the kind of population data that you're talking about was released by the Center for Disease Control and Prevention about, I think it's 8 to 10 years ago now. I know that the University of South Carolina's research center is working on an update of that, but it's not out yet.
Well, what about incidence of chronic conditions between the two populations? How do those differ?
Higher in rural than in urban for almost all of them. There's about a half a dozen that people tend to look at.
Diabetes, congestive heart failure, AMI. You also have higher rates of activities of daily living, limitations on rural populations, so recovery from stroke, things like that, all part of that spectrum.
Does that differ significantly by region of the country?
I think so.
Yes.
Certainly, I think you'll see a different gradient in the southeast than you would say in Maine.
That you think are...
That correlates a lot of times with what you see with the Dartmouth Health rankings, too.
And the regional variation is both urban and rural.
Finally, in talking about poverty and the definition of that, is that just based upon cash income? What I'm thinking of is rural populations can often subsidize lack of income with growing their own food, things like this, which are opportunities urban populations often do not have.
I believe it is household income, and I don't think at the federal, the poverty level calculations include assets.
No. All right, yes, at the
Yeah.
rear of the room.
Right. My name is Jim Slattery. I'm a partner at a law firm here in Washington, Wiley Ryan. I'm just curious how the panelists view how the enrollment process is going to work in rural America. Rural America is represented today by a lot of political leadership, both at the state and national level, that are really hostile to the implementation of the Affordable Care Act. So you have about 35 states out there that are so hostile that they refuse to set up their own state exchanges. So HHS is going to have to come in and set up a state exchange, operate an FFE in those states. I'm curious how you all see this enrollment process unfolding in those FFE states, especially given the just blatant political hostility at the state and local level.
We have a related question, actually, that just came in on a card, wondering whether, given the fact that there are so many federally operated exchanges in rural states, how well equipped the feds are going to be to adapt to the local needs that are sometimes a little different in rural communities. Yes, Lisa.
We were musing about this last night at dinner, and I think certainly in Maine, the more that we can start calling these products something else besides Obamacare, the ACA, or whatever, Maine-named products, the better off we're going to be, because the polls say when you talk to people about what these insurance products will look like and some of the benefits of the ACA, they're all for them. So, sort of politically separating the names from it. Secondly, I work for philanthropy, and the philanthropic world is particularly the conversion foundations that were created by the sale of Anthems, Blue Crosses, Blue Shields, big hospital systems, whatever, whose mission is access to health care. You are going to be finding in states with very healthy conversion foundation philanthropies, they are pouring a lot of money into enrollment strategies with both public and private sectors. And I think that is a factor that none of us really counted on before when we were thinking about the gearing up of this system.
One of the things that I would just also ask you about is, in the last couple of days, the department has issued their regulations and their agreements, really proposed agreements with web brokers. And what role do you all see web brokers playing in this process? Because many of these web brokers are licensed as agent brokers in the states, and therefore avoiding conflicts and issues about navigators and whether navigators need to be licensed as agents and brokers in, again, these states that are hostile to the implementation. What role do you all see web brokers playing in this enrollment process, and why hasn't this been talked about more at the state level?
No broker.
I can speak from New Mexico. The current brokers are not allowed to serve as navigators. They have to be trained separately. They can't have the kinds of relationships they've had with insurance companies. They have to be neutral. The problem we have is that you can have as many navigators as you want. Each time a navigator, like a PE MOSO worker, spends hours with an individual to try to get them either on the exchange or in Medicaid, that doesn't deal with the fact that 80% of the population in New Mexico who's uninsured doesn't know about what the availability is. And it's partly what you said about the hostility of the political climate that has so tainted this. But there are other ways, like you've heard of suppression of votes. There's also suppression of getting people enrolled. There are so many barriers to someone becoming enrolled, whether it's stigma or distance in a rural area, or, oh, they lost their application, or we didn't hire enough people in the Medicaid office to handle it. You're just going to have to wait. There are so many ways that even a state that has accepted Medicaid can slow the process, with many people having a view of Medicaid is it's a handout. It's just making people dependent. So I think that is the hugest problem we're actually now facing in our state, which has accepted Medicaid.
Okay. Yes. And you.
Hi, sorry. Just said that. My name is Sandra Wilkness. I work for Senator Heinrich from New Mexico. And yay, go New Mexico. My question is actually directed to you and others as well. But I'm very interested in this issue of social determinants of health and intervening early. And as we think about health delivery systems reforms that are on their path or coming, are we addressing that level of intervention? And if not, what should we be doing federally? And I guess a follow-up to that is, does anyone know if any innovation center ideas are being put out there to address this more broadly?
So I'll start. If you were to make one intervention that would have a bigger impact on health than anything else, it would get more kids graduating from school. The problem is it's a different system. So the health system uses its money for its own. We have to figure out a way to cross sectors of the community. One of the ways of doing it is, for example, pipeline into health careers. My feeling is it's great if they want to become a nurse. But it's even more important that they graduate from school. So we have to use the resources available to understand the impact on health of these other social determinants. We're setting up food pantries all around the state in food deserts, which are heavily in our rural areas. I think we're the third highest food insecure state because it's a health issue. You know, in a hospital, I'm doing drips for all kinds of intralipids. But then there are people without food out there. There's a disconnect between how I'm being paid and what communities need. So I think in every one of these major social determinants, the health system has to be incented to going out and doing something about it. And that's where these bridge people, like community health workers, are so important. They're bringing this reality into the front line of our clinics and hospitals, and it has to be ramped up.
I'll jump in really quick since they're over here buzzing. Another thing we're doing in Maine, and again, I work for a philanthropy that is very interested in primary prevention. We're a health philanthropy. We started looking into how do you prevent domestic violence. What you really do is step many steps back and look at the field of early childhood experiences, adverse childhood experiences, and how predictive it is that if you've been, as a child, exposed to a drunken adult, child abuse, domestic abuse, loss of a parent, et cetera, extreme poverty, the tracking of your chronic disease, not even to speak of all the social problems you may experience and the drug abuse you may experience, is dramatic. So we are now, in our state, we have a very large effort at looking at early childhood intervention, trying to alert helping professionals across education and health sectors to be looking for these adverse childhood experiences and intervening around them because they have huge health implications and chronic disease implications later in life.
Anybody else?
Just a couple of quick examples, because you asked where could you find some things. The Public Health Trust Fund that was in Title IV of the ACA has been funding some community transition grants around the country. So if you look up through a search engine, community transition grants, you'll find examples. Some of the innovation grants that are funded out of the Center for Medicare and Medicaid Innovation include addressing the social determinants of health. And there's a large program that the Robert Wood Johnson Foundation Fund has been supporting in public health. So if you go to any of those sites, you can pull down some specific examples.
I might add one thing to that, and that is the community transformation grants that Keith mentioned had a 20% rural set-aside in it. First time in my 16 years here, 17 years here, that in a big public health grant there was a rural set-aside. And I think it was a recognition of the fact that if you just, when you block grant those things to the state, it tends to be where can you get the biggest impact for the number. And that often is in the urban and suburban areas. So the fact that they explicitly said 20% of those funds need to go to rural communities was, I think, an acknowledgement and a possible path forward for how to address the fact that the disease states are worse in rural communities, and earmarking money for that and acknowledging it on the front end in order to change those outcomes.
Good. Zane, you've been sifting through a bunch of green cards. What have you come up with?
You know, in speaking with Lisa, and questions that come up in the type of delivery that's best done locally with the federally qualified health centers, there's a question asking, you mentioned the expression of FQHCs as a part of increasing access to care in rural areas. As you know, the CHC expansion has not been as robust as planned in ACA due to a cut in the discretionary funding in 2011, causing the CAC fund to backfill for the cut. If the expansion of CHCs had gone through as intended, what would the impact have been in rural areas? And I think both you discussed that, as well as Tom, you were talking about the funding mechanisms, if both could address that.
Well, I think it's hard to predict for dollars that aren't there, because they're competitive applications. So, I think you could assume that some of the funded applications might have been from rural areas, but it's so hard to sort of look back and say it would have been X number in the urban communities and Y number in rural. The fact is that between not just the ACA, but looking back to the Bush folks and their expansion, we've seen a dramatic increase in the number of health centers since 2000 nationally. And we see them in rural areas we did not see them in the late 90s, particularly in the upper Midwest and some of the more rural states.
You had indicated when you discussed that the deficit deduction proposal caused changes with the RHC and critical access hospital changes. What were those particularly?
Well, there were just, there are proposals out there about whether the mileage standard should be changed for critical access hospitals, which have to be 35 miles from another hospital. But there is a provision that allows some to be accepted from that mileage requirement. So there are some, about 55, that are 10 miles from another hospital. So the Congress had proposed, CBO had scored, and the administration has proposed to take that away. In other words, remove the designation from those 10 miles or less. And so what I had referenced was the committee had sort of looked at the impact of that and what it would mean. And then there were other, there have been a myriad of proposals around other rural hospital designations that the CBO had scored, eliminating Medicare-dependent hospitals, sole community. They weren't advocating it. They were just saying, if you do this, this is what would result in terms of savings. None of those proposals were acted on. They're all just sort of proposals at this point.
Very quickly, Maine jumped on the potential to expand community health centers during the Bush administration. And I think we did about as much expansion as we could support. I worry now if we expand many more health centers, whether we can recruit the staff for them. And also, the development of ACOs, and those of you who saw Keith's map, Maine looked really good. I mean, it was covered. We do have ACOs developing, and what's interesting is they don't seem to be talking to FQHCs very much because it is such a separate system. So expanding in Maine to more FQHCs worries me if the behemoth is going to be an ACO in the future.
Yes, sir. Go ahead.
Al Milliken, AM Media. Do any of you identify any further significant emergency room and ambulance services changes?
change is due to what? You mean future? What
Present
do you
and
see,
future, yeah, maybe what you foresee possibly too, yeah.
Oh, well, can I jump in? I'm
Please. No, go right ahead.
We did a recent study in Maine because our ER use is very high. In rural areas, you know, ER use is very high. The number one visit for ERs, particularly among Medicaid, was for dental and oral health care. So we're not solving that with the ACA. There's some improvements, but these two systems remain very polarized, not polarized, wrong term, separate. You know, we've gotten our behavioral health system moving closer to primary care, but oral health is still out there, and they aren't integrated. I've talked to ACO people. Are you going to include oral health in your services? Oh, no, we don't do that. Well, how are you going to impact your ER visits then? So I don't know if other states are seeing that, but there's a lot of interplay between oral health and primary care in the ER. And right now, the ACA is not addressing that.
Yep.
I think there's a real conflict that's going on now, where some hospitals don't want to see those ER visits go down. That's where they get their business. That's how they fill their beds. And so in that regard, some of our strongest partners doing the most innovative work for prevention are actually the managed care organizations who save money by decreasing ER visits. When I've gone to hospital administrators, we talked about lots of innovations. One of them is a nurse advice line in the States, the only one in the country, by the way. And I asked the hospital administrator, would you like to pay into this? So he said, tell me again, you're going to decrease me ER visits? Why would I support that? So we're in a transition of incentives, and as long as that transition, you have, in some regards, the more patients we see, we get more money. On the other hand, if we can cut down the number of people seeking care, we save money. And until that's resolved, and we're in this transition point, we're going to have this pull and tug.
Could I ask, as a part of the follow-up, there was another question here, and I think it fills in with this. But first of all, with Lisa, the direction of the dental provider in Maine. And there is a question asking if you could speak to how the efforts in Maine to authorize a new type of dental provider to go into the underserved areas. But at the same time, to follow up to get another question out of the same way, same discussion, is possibly for Dr. Kaufman. I know we talked about this earlier, but also including the role of pharmacists in supporting chronic illness management and reducing the prevalence of chronic illness through wellness and health reforms. Both of these questions go to the discussion we've had about using other options of types of folks to help provide the care.
I feel that the pharmacists are the most highly trained, underutilized members of the healthcare team. The dilemma is the money they make in retail pharmacy far exceeds what they can make providing patient care. There is a movement to increase clinical pharmacists. They're trained this way, but the jobs aren't there and the residencies aren't there for that. But when you look at their role in managing the most difficult diabetics, hypertensives, they're incredible. We're so reliant on them. The other role is if you go to any community, who can you see day or night for free? It's only the pharmacist. You go and say, what are you going to give? You know, I got a thing here. What can I do for this? And they'll give you some idea. You can go aisle 6. You get a little thing and put it on. But you can't do that with a doctor. It's 3 months unless you go to the ER and $1,000 visit. So the pharmacist we're moving rapidly to try to incorporate them, but to overcome some of the barriers I mentioned.
Hi, I'm Matt Brockmeyer with the States Alliance for Balanced Insurance Regulation, and this kind of dovetails nicely with the last response in terms of changing the way we utilize different healthcare delivery professionals. So just wondered if somebody could comment on the current reimbursement status of telehealth and telemedicine after the Affordable Care Act and how that could potentially impact some of the challenges unique to rural healthcare communities.
Well, the Institute of Medicine right now has a report out on telehealth from a meeting we supported with them last fall, and it addresses a lot of the reimbursement issues. The the ACA didn't change anything about the way telehealth services are paid for. It remains the way it has for the last couple of years. Medicare covers a small range of services. State Medicaid programs cover more. There's actually a resource guide out that sort of catalog the 50 states in which Medicaid programs cover and which don't. Private insurers have not really stepped up much outside of closed systems such as Kaiser. Probably the biggest innovation going on in telehealth right now, to my mind, is probably what's going on in the VA. And then Keith and I have talked that you know, as he talks about ACOs and shared savings, and we focus more on the outcome and less on site of service delivery, telehealth may be a more natural fit with where healthcare is going than perhaps where it's been, where the concern is always on volume and the payment for that particular service.
And some of the healthcare systems and organizations may be our early adopters of telehealth because they're seeing it as an investment strategy that helps them in their other approaches toward care management of patients, their other approaches toward making care more accessible, one of the leading examples being telehealth in the emergency room, and what that does to bring a board-certified physician into a virtual presence in the ER that starts out with a nurse practitioner or a PA that's physically on site at the time. And the payment support behind that is, again, those systems and organizations are accepting payment contracts that are global in nature, and or they're participating in some sort of shared savings arrangement. So by lowering the overall cost through the use of telehealth, even though they're not getting paid directly for the telehealth service, they're seeing a financial gain to the bottom line of the organization.
And I don't want to put Zane on the spot because I don't know if this is part of your area of responsibility or expertise, but it does seem to me that private organizations like Centene, getting global payments, as Keith was talking about, are in a position to use those payments in the most efficient way, including telehealth. And I wonder if that is something that you've been pursuing.
Well, we utilize telehealth in many of our markets. As you stated, we are on a global payment schedule. We have to treat the whole person, and we have to find the right care, right place, right time. And so if telehealth is one of the best practices that we can utilize and bring to the table at that time and use, that's a part of the schedule of how we serve the patients. And as far as we have contracts and we have other ways of paying for those services, but certainly it's a part of the considerations that we take in when we're looking at that.
Yes, sir. It's a familiar face.
Bob Rohr, BMJ again. For Art, you mentioned trying to tie in physicians, pharmacists more and use them. From what I've seen, though, the trend is almost in the opposite direction from insurers and payers, sort of the switch to centralized filling of prescriptions, mailing of drugs, giving incentives to patients to use this because it's more cost effective rather than, you know, use the local pharmacist. And so how are you seeing these forces play out between what you'd like to do to make better use of these providers and, you know, the economic forces that are pushing towards a more centralized, you know, and non-accessible use of pharmacists?
To me, pharmacists are very, very highly trained. A lot of what they do in retail pharmacy can be done by pharm techs. The problem is that the regulations in most states require that a pharmacist has to be there dispensing, you know, face-to-face contact. So one is that you could have a pharmacist, and that's what we're now developing in New Mexico, where a pharm tech can dispense, but if you have telehealth where the pharmacist can look at the prescription, look and talk to the patient that's waiting online, they can dispense. So you're keeping rural pharmacies open. That's one strategy. The second is that 52% of prescriptions in the United States are not filled. 52. So primary care, we write prescriptions, and we don't know until the patient comes back with diabetes out of control, hypertension out of control, that they didn't fill the medicine for a whole variety of reasons. So pharmacists are now taking roles in actually monitoring and informing the prescribing doctor when a patient doesn't pick up a prescription. When you start looking at how they could be used for, and then also with chronic care, really going over the details with patients about that role. So I think it's something that's coming. You're absolutely right. Right now, everything is volume and it's fast. But I don't think that's what's going to improve the health very much. It does improve access, but just for pharmaceuticals. But that's not the big intervention that has to happen. So every pharmacy school is trying to figure out how to get more of their graduates with clinical pharmacy certification, and then finding through the reimbursement that's currently changing with the ACA, how they become part of teams, just like we talked about with other health providers.
Actually, that raises a related question, it seems to me. Part of the way you're going to be able to use the pharmacist's expertise is, or the data that comes from that, is to be able to tap into data sources that'll tell you that 52% are not being filled. And that, in turn, leads me to question something that was referred to earlier, and that is the collection of data in rural areas vis-a-vis what's going on in urban areas. Questions like internet access and sufficient health information technology that are maybe a little more of a challenge in some of the rural areas. And I wonder what our panelists might offer in the way of observations there.
I guess I'll start reflecting on experiences in Nebraska, where I was until 3 years ago, and now Iowa. The technology is less and less any kind of barrier, both in terms of the spread of access to broadband capabilities and capacities. There's still some gaps out there, but they have shrunk considerably, and there are still some pockets of financial assistance available to help install the technology, either through USDA or through HHS at the federal level, and a couple of major national foundations that are still investing in expansion of broadband capacity. The larger barriers are related to what is the incentive for the local provider, particularly if you move out to the small rural clinic or the small rural hospital. What's their incentive for taking the personnel time and investment required to both install a system and then learn how to use a system? And then what is the operational trade-off when they're investing in that same capacity, both human and capital, over time? Those alignments really haven't fallen into place yet. The Meaningful Use Incentive Program that was in the legislation that was part of the Recovery Act has made a big difference. There are a lot of, I was just visiting in another state, some rural practices for one of our research projects, and one of my conclusions that surprised me at least a bit was every single one of them was meaningful use classifications. And these were relatively small rural primary care practices. So that kind of an incentive program interfaced in their area with an active system has made a difference and moved them forward.
Can I say something real quick? Here's a real practical incentive in Maine. Hospitals are not going to buy your practice if you are not willing to move into computer-based patient records. And so that is practically what's happening in Maine, and that is how a lot of rural practices are gearing up now, is that the hospitals are buying them. Of course, the FQHCs have been computer-based for their claims for a long time, and now their patient systems. So the reluctant rural practitioners in Maine will be retiring soon, I think. And we are a very data-rich state. We have all-payer claims data system, the first one in the country. We have one of the leading health information exchanges, patient information exchanges. We are now trying to merge them. So in a tiny rural state like Maine, it's going to be even more important to be able to access information through computers. So it's just inevitable in our state.
I've got a question for Tom Morris. What role does HRSA play in decisions regarding payment for providers in Medicare? And I guess I should add, what role would you like to play?
I think I'll ask the first part rather than the second. The role we play is that we review all the regulations as they're developed each year for the payment updates. So we're not so much in a situation where we're setting the payment. what we're looking at is, as we think about how the payment is constructed, with the conditions of participation that regulate payment that a provider has to meet, are those taking into account unique rural circumstances. Those are the sort of things we're trying to do, just to make sure that it's a level playing field. It can play out in a variety of different ways. For instance, you know, they may transition a certain payment because it has a negative impact on a certain provider class. Instead of doing the whole reduction in 1 year, they may space it out over 5 years to give people time to adapt to it. On the condition of participation side, it may look at, somebody may think, in a perfect world, you'd want somebody with an MBA to run a home health agency's business office. And that may make perfect sense sitting in an office here in Washington, may not make much sense sitting out in a very rural area when somebody's been doing that job for 10 years and maybe they only have a high school degree or an associate degree, but they're doing a fine job. So what we try to do is just provide that sort of rural lens to say, you know, is this actually needed? Is it fair? And how does it fit into the rest of what we're trying to do with that particular regulation?
Zane, you have anything?
Sure. There's been a discussion with regard to a lot of primary care. This question asks us to expand that, and I think Dr. Kaufman, in a prior conversation, this is something you might have addressed, but can you speak to the impact of access to mental health services on population health in rural areas?
So about 40% of what we see in primary care is behavioral health related. 40% of the discharges from our hospital are related to alcohol and substance abuse. And of all the high utilizers, 70% of the underlying causes of those hospital discharges, of those high users, are behavioral health. And 70% of that is alcohol and substance abuse. So the question is, how do you get alcohol and substance abuse and behavioral health treatments into underserved areas? Back to our telehealth discussion, one of our booming telehealth needs and resources is telepsychiatry. I don't want to keep saying cooperative extension is everything, but it is everything. They've actually, I couldn't believe it, as part of our collaboration with them, their Family Consumer Sciences actually train family counselors all over the state. They need to work more with supervision, so we're now having some of our psychiatrists do supervision with them. It's just another way of trying to increase resources. It's not going to come through enough psychiatrists. It has to be other kinds of counselors, licensed social workers who can do counseling. And also this mental health first aid can have a substantial impact. So I think you have to step back and look at what is available, who is there, and how can you train that resource. When you have more technical, difficult problems, you have to use telehealth. Unfortunately, in New Mexico, there are so few places they can send someone who is very ill. Those doors are closed. And then what do? We leave community hospitals with this very, very difficult patient to care for. The families are stressed. They have no place to go. So we have to accept this as a burden that we take on, not just them. It's very easy to say, gee, I'm sorry about that. We can't do that anymore.
Yes, go ahead. And before you ask your question, I might just say that between us, Zane and I have enough green cards to last through the weekend. We are not going through the weekend, so if you really are absolutely dead set on getting your question addressed by the panel, I commend the microphones to you. Yes.
My name is Barbara Levin, and I've just retired from 33 years of one of the 40,000 National Health Service Corps people who stayed in their community. And I'm really impressed with your retention numbers. I was in rural East Tennessee, and the thing that hit me the most were the people who came and went for 2 years, which really decreased the reliance of our population, our community, on those types of people, because they didn't really want to have someone who just came for that short period of time. I'm wondering, it's good what you're doing with the short term. Is there something that we can do, and do it a lot earlier, to address redefining rural practice as something that will be, I don't want to use the word as supported, but as that you will get some sort of ongoing recognition that this is a very important role to have. One of the things that Lisa brought out was that as the ACOs developed, there are going to be fewer and fewer people working where I was working in a community health center. And the second thing is that all these issues around telemedicine, if there is no one out there to turn on the TV you don't have anything. So I'm here to say that it's very, very important that we work on this retention and we work earlier and we identify to all those young doctors who are going to primary care medical schools that there really is something there, because most of them are graduating fewer than 10% of people who go into primary care. Thank you.
Let me just add something, because I think it's so, what you said is so important. We looked at our data over the last 30 years. If you come from a rural area, you're 6 times as likely to go to a rural area. But to do that, you have to change your admissions procedures to all the health professions, and that's tough when an admissions committee likes to clone themselves, but we're changing that. The second is, if you're from an ethnic minority in our state, your likelihood is even higher. And if you've trained, if you graduated from high school in our state, and you went to college and medical school, it's even higher. So we're putting those factors in to try to change this whole notion of who we're taking in. It's not how we're going to look good on U.S. News and World News Report and there's high scores. It's, do we get graduates where they're needed around the state? The second is where they train and how you support those sites, like the service corps sites. And what we're finding is if you can make them much more academic units, it means the center of training is decentralized. We're finding for the National Service Corps, FQHCs, those have become highly desirable, even though the pay is lower, because it fulfills another yearning that graduates have of doing something important in communities.
Right. Just to say, I'm from Berlin, New Mexico, so.
Did you meet the Heinrichs person?
Anyone else?
Well, can I ask a follow-up question?
Yes,
on that?
go ahead,
Part of her question was also about what incentives might there be for the short term as well? I mean, that's the long-term goal of getting the graduates into practice and into the rural areas. What can we be doing now to guarantee that there's some stay power to be involved rurally now, and to incentivize maybe the hospitals, as Lisa said, that are actually hiring the providers to participate in that practice?
Certainly in the short term, I think rural clinicians have got to bite the bullet and decide that teaching and training is also part of their responsibility. And there's, I live with a rural physician, there's a lot of whining about, oh, life is so hard. But guess what? He was an urban child who had a rural health center experience at UC San Diego. And he lives in a town of 500 people now and practices in a rural health center. There was something magical about that experience in rural San Diego County that flipped him. And those experiences are very, very important. And I think rural practices and rural hospitals and larger community hospitals have got to be very purposeful about preparing clinicians to be teachers as well in those settings, to unveil and portray the wonderful life and the embeddedness in community. If you're seeking community, you need to be a rural physician.
Add a state example in Nebraska where I was previously. The state has had for a couple of decades now a highly successful pipeline program that brings all of these pieces together, starting with introducing the sciences to elementary age students, so the university sponsors an 8th grade science fair, all the way through admissions policies that favor people that come from rural places, shortening the length of time that it takes for them to go from entering the undergraduate college to completing their medical training, including rural residency training tracks, including training tracks during their undergraduate, and then residencies. And they've been at it long enough that before I left there, we were beginning to see the data of the 8th grade science fair students who are now practicing clinicians in rural places. And it's that kind of comprehensive approach. Any one of those pieces is important, and I agree that each one of them, there's some data that says this increases the prospect. But combining them all into a single pipeline program, adding in some elements of loan repayment, is sort of the sweet spot we should be looking for.
Yeah, because the only thing I would add is, you folks have said it nicely, but it's workforce is not a federal responsibility, and it's not solely a state responsibility. It's a shared responsibility that also includes local communities, and so that continuum of activities is really critical. And there are full of states and programs that have really figured out. There are just not enough of them.
You know, our last question referred back to something Lisa Miller was saying, and that is that FQHCs are finding themselves a little bit behind the curve in being acquired anyway in what looks like the coming wave of consolidation. I wonder if that's more generally true across the country, to your knowledge, or is it something that is unique to certain specific areas?
Well, one thing I might add is just, you know, FQHC's incredible important part of the safety net. Rural health clinics, which are just a payment designation under Medicare, also critically important. They're both paid differently than we pay physician practices, and that's a good thing because it's a recognition that's been in place for 25 years that they needed cost-based reimbursement in order to get the providers out there and ensure access to care. But as we've moved into these new models where, like ACOs, we've had to figure out how to blend people we pay on a fee-for-service basis with how we pay for folks in a cost-based environment, and it's very difficult. And as a result of that, that's where you see some of the issues I think Susan was referring to about it's harder to bring them into the loop sometimes. But folks are figuring out workarounds around it. FQHCs are moving to a prospective payment system, which will include claims-level data, so that will help. So I think that things are going to get better in that regard, but it has been a bit of a challenge.
On the CMS website, you can, and CMMI, you can see some data about how many critical access hospitals, FQHCs, and RHCs are currently participating in ACOs. The numbers are very, very small, but they are there. So one of the things that we need to understand is how did that work for those ACOs and those FQHCs, and can we spread that knowledge around more? I mean, the whole genre is still so new that there is time and opportunity for those organizations to come together, but a lot of that's going to have to happen at the local level again among the organizations. It's not something that a policy lever is going to make happen.
Yes.
Hi, my name is Casey Tilton with the Association of American Medical Colleges. My question is specifically for Dr. Mueller. Had a question about, or you had mentioned briefly programs that had been implemented in Iowa to promote doctors practicing in rural areas, specifically for medical schools. Can you mention a little bit more about that and what impact that they've had so far?
In Iowa, there are two things that have occurred. One of the examples I just gave about pipeline was from my previous iteration in Nebraska. In Iowa, there are two particular initiatives that are very new. One of those is a loan repayment and incentive initiative that the governor promoted this year and the legislature enacted. So there are some state resources being devoted to incentives to get healthcare professionals to distribute more across the state. And the other is from the University of Iowa's Medical College, which has also created a loan repayment program for its graduates that go out and practice in rural, underserved areas. Both of those are still pretty new, so I don't have the advantage of a lot of evidence, like the example I gave in Nebraska where the program's been in place longer. And again, in Nebraska, it's a full pipeline that starts with activities at elementary school and goes all the way through the admissions process, education, and residency.
We have only about 5 minutes, so I would ask you as we go through this last Q&A or two to pull out those blue evaluation forms and fill them out as you listen. Yes, you may have the last question here.
Yay. Hannah Kessler with United Health Group. I was just wondering what some of the biggest challenges you find are with children's health in rural areas. What are the biggest challenges that you guys see?
I wonder if you could say that again a little more closely to the microphone.
I'm wondering what you think the biggest challenges for children's health in particular are in rural areas.
Okay. Done there for children's health?
Poverty. Plain and simple, poverty. The rise in poverty among children in Maine is pretty astounding lately. And I'm not entirely certain what it all is, but certainly the recession has not helped. And it just stands out to me all by itself.
I would add to that, I absolutely agree. You know, if a parent is uninsured, that child who has Medicaid gets 20 to 25% less care because the parents are not connected to a system. And the stress that parents are under affects children. In our state, we have a very large undocumented population, and that is not covered by any of the ACA or any other. And there's a constant struggle. They're a vital part of our economy, and even most of those kids who were born in the United States have Medicaid, but their parents are always threatened with being deported, and so the stress level is extremely high. The other I'd say is it's an age-dependent issue. Most family docs, pediatricians see young children. When you get to be teenagers, who the heck wants to see a doctor? They're so needy, but you can't find them. That's why you have to set up school clinics. You have to go where they are because they're going to keep away from you as much as they can. And yet the needs and the transitions are so high at that point.
Lisa? Zane, you have a final question for us?
Well, just as a follow-up possibly to that, to dig a little bit deeper into what Dr. Kaufman just said, you know, access and navigation to care is one of the largest problems that they have in the children-based populations. But with that, you discuss the school-based health centers. And I know New Mexico utilizes school-based health care, and how do you view that, getting back to some of the questions that were brought up about screening and then the follow-up care, because screening is a detection, but what do you do to make certain you get access to care?
So we said, I think we have one of the highest rates of school-based clinics in the state. And we started with students and residents, and then when they stayed in state and went to rural areas, they set up their own clinics. And what was interesting to us is what we found. When we polled all the providers, what's the number one problem in teen health, for example, because most of these are high school clinics. And we said, it's really teen pregnancy. But when we asked the kids, that wasn't their number one issue. Their number one issue was feeling social exclusion. There's nothing is as bad as being excluded from a group. That's a fate worse than death. And so they were dealing with behavioral issues, and so we had to change the nature of what we did in those schools. Oh yeah, we deal with the behavioral, but we really had to go into classrooms and do a lot of counseling, brought in our other counselors, because that's the real issue. And it's closer to what the real risks are for those families. And then dealing with the local families is critical. So the whole nature of what those school health programs provide has changed.
Okay, good. Well, I think we've covered a lot of ground. We've left a lot of ground to be covered, but I want to thank you for some wonderful questions, including the ones we didn't get a chance to address. Thank our colleagues at Centene for participating in and helping support this briefing, and thank our panel for, I think, a wide-ranging discussion, and ask you to help me thank them in the appropriate manner. And consider this a telethon-like plea to help us meet our 50% evaluation return goal.
Thank you so much for allowing me to participate. Really good. Thank you very much.
I think there might be a meeting.